There you go. Perfect.
Okay, thank you. Sorry, that happened to me last time. Thank you. All right, this is just a short case. I wasn't for sure if we had multiple cases. And this is actually a patient that we're actively managing. So definitely I'm looking forward to the discussion for this patient. It is a 16-year-old Black male who has hemoglobin SS. Past medical history is significant for asthma. He has a history of recurrent acute chest syndrome and also sleep apnea. He's had his gallbladder removed and his sleep apnea corrected with tonsils and adenoids removal. From a social standpoint, he lives with both parents and he has an older sister who also has a sickle cell disease. He's currently prescribed hydroxyurea. He had endorsed his poor medication adherence. Right now, he's on about 16 mg per kilo, which for him, I would say is subtherapeutic. He's one of our patients that resides about two and a half hours away, and we've had fragmented follow-up since COVID had some challenges with getting him in from barriers with transportation. And I listed his labs here, but I'm gonna give a disclaimer. He was actually transfused right before. I meant to remove those, so we can talk about that in a second. He was transfused a few weeks prior to those labs. So other medications, he's on Symbicort for his asthma control. He also takes Claritin and Flonase for allergic rhinitis. And his typical pain management at home includes ibuprofen and hydrocodone for pain unrelieved by ibuprofen. So I met this patient probably 2-3 months ago for the first time. He was hospitalized back in, I believe, November for acute chest. So I saw him for follow-up. And when he told me about his challenges with his low adherence to hydroxyurea, both him and his sister just doesn't take it at all. I discussed Adakveo. So we did get them started on Adakveo. His first dose was in December, but he never made it back for his subsequent visit for his 2-week infusion, then the monthly thereafter. So what's presently going on, he presented to our ER here yesterday with from his primary care office complaining of persistent head and neck pain and also bilateral rib pain in his ribs. His headaches are associated with photophobia and phonophobia, but no nausea or vomiting. There's no history with him or family of migraines. Prior to his arrival, he was treating his pain, his head and neck pain with hydrocodone with no relief. In the ED, they treated with compazine, Benadryl, and fluids with no relief. And so definitely worth noting, prior to this, his presentation yesterday, he has been hospitalized twice at outside hospitals about 2 hours away and twice here at UAB over a 2-month time span, all for pain. His last 2 hospitalizations here at UAB, he was admitted at the end of January for leg and arm pain. He was with us for 7 days. And however, he went home and that same night developed pain, was readmitted the next day and stayed with us for 12 days. And he presented with neck pain, head pain, leg pain, abdominal pain. During this hospitalization, he developed fevers and an O2 requirement, so he was transfused and treated for acute chest syndrome. On his chest x-ray, they said that it was, they noticed atelectasis and concern for consolidation, but couldn't definitively say acute chest. He also developed some right jawline pain. They did get a CT with no evidence of infection or infarction. So during the second hospitalization, the 12-day stay, he presented with persistent fevers ranging from 101 to 103. Blood cultures were negative. His viral panel was negative, COVID negative. White count stayed around 13 to 19. Elevated platelets, I should say 4,000 to 8,000. That's a typo. Sorry. STI screen was negative. He was evaluated by dental and infectious disease. Both exams were benign with no recommendations for treatment. The team talked to neurology after the fact and said, and in retrospect, it's possible he could have had a viral meningitis. However, they did not, he did not get a spinal tap, so we can't truly land on that. They did, given his persistent fevers with no definitive source, they also consulted rheumatology. He did have a positive ANA, and they did recommend, given his back-to-back episodes of acute chest, they mentioned sarcoidosis. They looked at that angiotensin converting enzyme level, which was normal, so they ruled that out. There's also, and that's from the medical record, that's all that I can see as far as from an ANA workup that they looked at, was just looked at his lungs. So my question for the group, looking further into his chart, with both of his most recent hospitalizations, he was in for 7 days and then again for 12 days. So basically about a 20-day stay. With both hospitalizations, he was discharged with ibuprofen and hydrocodone. However, he had been with us for 7 and 12 days and he was on a PCA. So just for those with more experience, is he's showing us signs of opioid withdrawal, which that's what our inpatient team right now is currently at the top of their list. And then also just given his history of the positive ANA, I want to get some insight on if anyone has had experience diagnosing or ruling out lupus in the setting of sickle cell disease. That's it.
Excellent, thank you.
Mhm.
Well, I'll start with lupus. We have actually several adults with dual diagnoses of rheumatologic disease and sickle cell disease. Usually they're fairly easy to diagnose in terms of their ANA, DSTNA, C3, C4s. So we've certainly had our fair share of those individuals, as well as in, in the other rheumatologic diseases.
Randy, how high was his ANA?
Let me, hold on, I got his chart pulled up here.
Because you get a lot of these 1 to 80 ANAs that aren't anything.
Yeah, that's definitely true.
Hold on, I'm pulling up his referred testing.
My other question was whether he, you mentioned neck pain a couple of times. Did he have an MRV? Did I miss that at all? Because we have seen sinus venous thrombus in this setting.
He did not.
He was 1 to 40, I think. Brandy?
Yes, thank you. I just pulled it up. Yeah, 1 to 40. Thank you, Jeff. Yeah.
Question is, sorry, this is Dr. Moma. Was that the reflex? Typically here we do the ANA with the reflex. So it typically should reflex to the double-stranded, the RNP. Were those done, and did any of those come back positive? Because a positive ANA is totally useless in the medical world, which I am in family medicine. You have to have a positive dsRNA or DR or RNP to run with it. So I don't know if we had a reflex on the DNA.
Right. I'm not seeing, Jeff, I may be overlooked.
Yeah,
I didn't see the
we
double
would have to send out the full
send out.
ANA panel.
Okay.
Yeah,
Yeah, so the way we order it typically is you do a DNA reflex, which means if it's positive, they automatically do a reflex. So now you probably have to do another stick to get a reflex, because you need a dsRNA or an RNP to make a categorical diagnosis of lupus in the setting of this patient, because there's so many differentials within that rheumatological family that you need something specific to hang your hat on. Then if it's positive, that's when you start involving the rheumatologists. Here in UMC, they don't talk to you except you have those reflex back that shows what you're thinking. Yeah. But I see rheumatologists saw him already, or they recommended sarcoid workup.
Chart pulled up. I'm sorry. Okay.
Brandy, has rheumatology seen him, and did they recommend workup?
They saw him during the last during his last hospitalization. For this one, he just presented I think, early AM. So I don't see where your rheumatologist has seen him this go around, but I told the inpatient doc I would present him today just to get additional recommendations. I figured we would have some people with more experience. Sorry, I'm having trouble here.
So
You were here.
it's a low titer, but
Right.
normally we don't go by the titers alone. So if there's a clinical picture, maybe then an ANA, you know, some people say the titer tells you the severity or the acuity, but you know, some people say low titer is less likely, but you can't really hang your hat on that. You need the reflex. That's the next best step from my clinical point of view.
Thank you. It's helpful.
So I do general peds and general medicine, so I'll just weigh in on the ANA as well. And I agree, an ANA in and of itself is essentially useless. I think 20% of the adult population will have a positive ANA and it has no meaning. I don't necessarily agree with a reflex because you want to be thoughtful in what you choose next. So if he's having symptoms that you're concerned about lupus, then do a lupus workup, double-stranded DNA, C3, C4. If you're worried about RA, do an RA workup, CCP, rheumatoid factor, image, whatever's bothering him. I apologize, I came in late. It's a little chaos here. But why was the ANA done? Just the fevers?
Persistent fevers, yeah.
Okay, so there was actually no like other lab findings or exam findings concerning for a rheumatologic disease. Yeah. I don't know. Did you figure out why he's having fevers though?
No,
No.
they just said in retrospect, potentially a viral meningitis with the fever and the neck pain, but again, they can't land on
Yeah.
that.
I mean, it'd be interesting what Room says.
Oh,
I would say Room, one second, Molly. I feel like Room will probably tell you to shotgun it and check all the labs because that's what they usually say.
Okay.
But my guess is that not.
It looks like room suggested sarcoid workup from what they said.
I'm sorry, say it again. I'm
Randy,
sorry.
am I correct? There was a note that rheumatologist suggested sarcoid workup, and I agree with you totally. If there's no clinical symptoms of lupus, you shouldn't be chasing lupus. So I joined late, so I don't know why she presented, but right, if you don't have the classic skin, mouth ulcers, joint pains, you know, you shouldn't be pursuing lupus in the real sense of the word, you know. Hair loss, those are the kind of things you're looking for. Hair loss, mouth ulcers, joint pain, skin rash, skin lesions. You know, but it'll be interesting to know what they're thinking of.
Thank you. Yeah, I don't think they're necessarily, I just had the question with the ANA. I have limited experience, so this was helpful more for me. So I appreciate that.
And then just one more thing about the ACE level, like you can't hang your hat on that either for sarcoid. So a lot of people with sarcoid will have a negative ACE. So they actually, at least in the adult world, have really moved away from even checking ACE levels. So it doesn't mean he can't have sarcoid, I guess. So if there's clinical concern for it, like hyaluradenopathy or findings on lung exam, it's still definitely a possibility.
Thank you.
But there was no hyaluradenopathy though, at least from what you said, right?
No.
No, it sounds like there wasn't. I'm just saying if that comes out, and I wouldn't say just because he has a negative ACE that it can't be sarcoid.
This is Ben here. I know sometimes when we have kids with sickle cell and they present with pain that's not typical of what they normally have, and you get lost. They've been in the hospital for several days, being readmitted. We will sometimes get an ANA just to screen. There may be some autoimmune disease to see if you may find something other than sickle cell. And I know you don't want to go on a fishing trip, but sometimes that pain does not just fit what you know them to usually have. And I do encourage people to think outside the box, try to see if it's something else. We actually had a 14-year-old a few years ago who we got a positive ANA, was actually pretty high titer, and the rheumatologist just told us, no, it's sickle cell pain. Because they hear sickle cell, they say sickle cell, they have pain. You say, no, this does not feel right. She's having this more extremities, more joint pain. It took about 6 months before they will finally see the patient. And she did end up with a form of rheumatoid arthritis. So I do sometimes, I don't check routinely, but if the pen is just not fitting the pattern, I would sometimes get an ANA.
Thank you.
Hey, Brandy, has he had any imaging?
Yeah, so Jeff just sent me a,
I don't know if I can, are we HIPAA compliant or not? Because this has his name on it.
oh, okay, I can't see it.
Really, are we? No,
I don't see his name.
No, you can't use names.
okay, then yeah, I just sent you a picture of it that I took off the name, Brandy.
Okay, thank you. Let me see.
Because, you know, occasionally you'll have somebody with an epidural abscess if he's got persistent neck pain.
That's what I was
and
asking.
anger.
I thought that collection looked impressive to me.
Okay,
That looks like a little subdural. No? Is that current?
That's subdural, it does look like.
Is this current, like now?
That was yesterday, that's right?
Yeah.
Let me see if I
this
try to see if I
was,
can pull this up without
okay,
sharing a name.
Oh, it's not a normal CAT scan for sure.
Let me see if that would work. Oh, I can't share it.
oh, let me stop. Hold on. Okay, see if you can.
All right, I guess everybody close your eyes until I can figure out if I did this correct. Right, I've covered up this person's name. Oh, but as soon as I do this, it's going to show it. Yeah, so let me stop sharing so I can figure out how to do this better. Yeah, I don't know how to do it without, because once I click on the image, it's going to pull back to his name.
Sounds like you need more imaging based on the little that we've seen, the neck pain and those concerns. And I would get an MRV and as well while you're in there. What was the concern for withdrawal? I think I missed that. Or I missed how that fit into the story.
Yeah, yeah, I mean, it looks impressive.
Yeah, I mean, I don't think that's normal unless he's really. They didn't read that as anything?
No, they read it as, I'm getting it. They say small non-specific scalp fluid collection over the right frontal region. You know, because we've had patients who died of cranial epidural hematomas, and they have presented with orbital swelling, headache, but they did not see, they did not see a cranial, an epidural hematoma.
Yeah, I've seen both epidurals and subdurals during vaso-occlusive crises. And also have seen, we had a recent patient, a youngish patient, not far out of transition, who had neck pain, was found to have an aneurysm. Lots of reasons to image this kid's head. Further, I mean. What else?
Yeah, because this was ours where we had,
Yeah,
in 7 of the 25 patients, their initial clinical presentation was scalp paraorbital edema.
There should be an official read on the CAT scan, right?
That's what I'm saying. It says just small non-specific scalp fluid collection over the right frontal region.
Okay.
It says the calvarium is diffusely, is diffusely only thickened. I don't know what that fully means.
Okay.
And I don't see a note from today yet to tell you how the patient's doing.
and what are you doing for him again right now? I got lost in the weeds.
So right now they're treating as, they tried migraine treatment, but with no relief. And so they imaged his head. It's like, it's hard. We don't have a note. I'm sorry. Yet. I think they have him on, trying to see, pull up the flow sheet. This is wrong admission. Jeff, you're able to navigate quicker than me. Hold on. So they have him back on morphine. Yeah, they're basically treating him as pain right now, and they imaged his head.
Okay,
Yeah,
with just
that's-
that CT though, not with MR, right?
Right.
Yeah, so it sounds like he needs more in-depth assessment of his head and then go from there maybe.
Make sure.
The inpatient tending is really busy. He said his pain, his head and neck is better. It's just rib pain right now. That's the major issue, but he can't get on right now, the inpatient tending.
Well, keep us updated next time. Let us know what happens.
Thank y'all for your help.
All right, and instead of a didactic today, we're actually going to do a second case presentation unless someone spontaneously wants to do a didactic. Anyone? All right. This is a patient my UAB colleagues know very well. But I thought it was interesting to bring up for a number of reasons. Once my computer works, for discussion, and let's see. All right, so this is Joe. Joe is not obviously Joe. He's a 22-year-old. He has SS disease. He has a history of very frequent pain, admissions for VOC, acute chest in the past. He actually has a history of AML as well. He completed therapy in 2017 and was transferred from Children's to UAB at the beginning of 2019, actually like only about a month or two after I got here at age 18. He had a history of silent cerebral infarct during 2017 as well and was on apheresis. He also had a history of recurrent priapism, iron overload, and strep pneumosepsis as a child. As a result of the history of AML, he's been on exchange transfusions with apheresis, really avoiding hydroxyurea given his AML. Social history of drug abuse, probably physical abuse from both parents. At the current state, he's living with his grandmother, but that's a back and forth sort of thing. When I first met him, he was living with both grandparents. Didn't finish high school, but he got his GED. Healthy history of marijuana use, sometimes some other substances. Significant mental health history, history of anxiety, depression, PTSD. Only since I've met him in 2019, he's had 2 somewhat true suicide attempts, ideations. One was taking 30 Zoloft after getting kicked out of his grandparents' house because he'd been threatening his grandfather, so they kicked him out. And then several months later, a melatonin overdose in 2020, or I might have gotten those backwards, when he just wanted to sleep. Never really kept by psychiatry despite these. I think that based on what I can remember from these episodes, psychiatry almost didn't believe they were factual, actually didn't believe that he'd really done either of these things, that he just stated he had done them, and that he was very regretful, didn't want to hurt himself, all those things. So from 19 to 21, really, despite solid apheresis, S levels under 30%, hospitalized several times, about 6 a year. That's supposed to be 6 a year with VOC pain, often staying 5 to 7 days, often argumentative, disruptive. I get lots of red alerts in the chart from him of not getting pain relief or sufficient medications. He actually lost the ability to come to our day hospital infusion area because he was just so inappropriate, yelling, screaming, cursing at nursing staff, disrupting others. This was in 2020, and he was able to initiate psychiatry and counseling, and then he could come back into the infusion therapy. But one particular additional episode after that time, he knocked a bunch of stuff over in the waiting room, really destroyed some property, which led to his dismissal from clinic. As you can imagine, this was not good for anyone. So after that, he was hospitalized still several times. It actually should have been monthly at that point. Again with VOC pain, but now with frequent acute chest. And so we started, every time he came into the ER, we would exchange him from there. But despite his exchanges, he would still stay 7-10 days each time, remained argumentative, disruptive. So we finally agreed to a plan of care for him to come into clinic. This is present time now with police escort, monthly for exchanges, but he cannot come to the infusion therapy unit, the day hospital, because we can't plan those, acute visits in advance and can't arrange for the police escort, which was required by UAB given some of his disruptive behavior in the past. So where he is now, and the reason I bring him up is that, and I'm sorry I didn't get to finish my slides earlier today, but he actually came to the ER yesterday for acute pain. We saw him last week in clinic. It was his first police escorted visit. It all went fine. One of the discussions we've had is that he may no longer get Percocet because that seems to worsen some of his behavior. Of note, he'd also recently purchased some Percocet on the street, except it wasn't Percocet, it was fentanyl, which we've seen, by the way, as a common problem, as people buying what they think is oxycodone on the street and found to be fentanyl. But when I asked him about it, he said, God, no wonder I felt so weird and awful. So, it was very acknowledging of it. We talked about, we're not doing you cannot have oxycodone. And talked about a plan to trial some Dilaudid at home in very small increments because of the many issues that he has. So he came into the ER yesterday, wanting pain medication, really wanting to be admitted. Our hospital is balls to the wall full at the moment, and he really didn't need to be admitted. His S is about 20% at present. And in between screaming at people, he was calm and seen to be very okay. So he'd already, of course, taken all the medicine I gave him. I offered to refill his pain medicine. He cursed out a number of individuals within the ER. And then he was getting IV sub-Q medicine at first. So we switched him on, let him get port IV medicine through his port. He then absolutely refused to have his port deaccessed, actually requiring security in the ER. We finally got port deaccessed. And as he left, he called over his shoulder, and I'm just going to go home and kill myself. And then proceeded to call every phone number he had for UAB clinic. So I had multiple people calling me yesterday about the concern for my suicidal patient, who the triage nurse was like, yeah, he was buying cigarettes while I talked to him. I was like, well, not that suicidal. Anyway, we sent him back to the ER where he was held overnight by psychiatry and released today for reasons that are beyond me, actually. But he states he's not suicidal. He was just in pain and wanted someone to listen to him. So how would you manage this patient from a behavior perspective? And what are your program rules regarding disruptive patients? Floor is open.
I thought we had sorry to put it this way, but the social worker does that better than I thought. That's my opinion. In this kind of situation, you look at the social demographic and the social dynamics, because I think it's hard to manage this clinically. I think there's a lot of social parameters that need to be addressed.
Yes, but short of adopting him into a new home, there's very little we can do to affect that, unfortunately. Social work has been utterly involved in this individual's care since he came from Children's over to UAB. Of course, yesterday, one of the social workers, not a sickle cell social worker, when this phone call came, she came down to clinic and said, basically, I'm not going to talk to him, you talk to him, which was highly inappropriate, and we're addressing that as well. But what do you do with a disruptive individual who does desperately need care? Without care, he has recurrent acute chest, he has a history of PE, not to mention AML, and silent infarcts. And I do consider it unethical to not give him care, but giving him care is quite difficult. Arkita, what would you guys do? I'm calling on you because I see your name, sorry. You know what the policies are at University of Tennessee?
Well, we have two different clinics. Our policies are typically the same. We warn patients if they are disruptive, we give them written letters. But we do dismiss patients from clinic who have bad behavior, either unruly to staff or unsafe or threatening. And since we have two centers, they may get dismissed from one and go to the other and may eventually get dismissed from both. But we do dismiss patients from clinic for bad behavior. They are, of course, still seen in the ER if they need to. But yeah, we have a no tolerance policy for abuse and violence. And so I understand like this is really tricky because this patient has so many medical needs, but at the same time, if you guys are at direct harm, then that gets really challenging to try to give this patient care.
Yeah, and that's why we've arranged for the escorts, and he's not allowed to come to clinic unless escorted. So at least we can get his exchanges done, which I felt like was the best thing I could do for him, which took, several months of finagling.
Right. I mean, I think that's great. I've never even attempted that. So I think that that's great that you were able to do that.
But I sort of feel like this is what I got for that. That was, went great a week ago, and then
he's your baby now. Like they want you to fix it.
But I wondered if anybody else had any other thoughts.
Do y'all have a relationship with anyone in his family? I know it sounds like he's kind of burned a lot of bridges, but did you all get a chance to just establish any type of rapport with anyone in his family?
We have a semi-rapport with his grandmother who called us several times begging us to bring him back. We actually, when we first dismissed him, we arranged for him to go to another hematologist in town to continue manual exchanges. I had hoped that that individual would have a better influence on him as a male physician, that maybe he would be more receptive to that. We don't currently have any male hematologists in our group, and unfortunately managed to get himself fired there for similar threatening behavior, cursing out their staff. And you can imagine how well that went in their little private practice office. So, we have become this kid's last resort. He's back to living with the grandmother, though he tells me that he is on the verge of getting kicked out again because, he wants to be young and go out with who he wants to go out with. And he doesn't care what grandma's rules are. I mean, very much has a sort of oppositional defiant disorder, but underlying all of that is a lot of anxiety and PTSD and, heartbreak.
Yeah. I think I would like to comment on the case as well. And I am Callie Morais. I am actually the new psychologist in the team, working with Dr. Kanter as well. And I think on this scenario, and I think with a lot of patients, consistency of boundaries and just kind of saying the same message across all staff members, from the physician to the person that answers the phone, like everybody needs to be on the same page. That can just communicate the message to him so that he doesn't pick people that he wants to be splitting with or whatnot. And then the other thing to remember too is that, yes, he might be dealing with a lot of social factors, a lot of mood factors. All of these things are definitely going to have an effect on his sickle cell, and his pain flare-ups, and he's continuing visits to the ER and whatnot. So if possible, kind of communicating those messages to the patient as well to see if that clicks at any point. But I mean, this is very challenging and very emotionally draining, I bet, for everyone interacting with patients like this, but just consistency with boundaries and just saying, like Dr. Kanter said, like the person up front said, like we all agree that this is what we're going to do this time. And if you don't do this, then you can't come back. And that's all I think might be helpful at this time.
Yeah, no, I think we are very consistent, but the problem is when he doesn't get his way and tells everybody he's going to kill himself makes for a very difficult environment for everyone.
Yeah. And at that point, I think what happened yesterday, I think it's the best thing, right? Going to the ER and he knows the sequence of events.
Yeah, hopefully. We'll see.
What role do you play? I mean, in terms of psychiatry, I know you have a psychologist, Dr. Morales, on your team, but what role does psychiatry in the pharmacotherapy world play for this guy? Does he see a psychiatrist?
He does, actually. They're not here, so I have to call them. It's psychiatry is definitely challenging here. If they would diagnose him with something meaningful to psychiatry, i.e. schizophrenia, bipolar disorder, then perhaps our psychiatrist would actually see him here. But as of right now, he's seen outside of one of the outside mental health groups, but he is seen by them. Whether he takes the medication, he's prescribed Seroquel and is now on Lexapro and Seroquel, but whether he actually takes those is highly questionable. But it was required. One of the only ways in which I allowed him to come back at all, even with security, was that he had to see psychiatry. All right. Any last thoughts? All right, Brandy, we will look forward to an update in 2 weeks from you guys.
Okay.
And we will go from there. And thanks everybody for joining us.